Today's topic is severe acute malnutrition. Those who have the textbook, chapter 8, page number 155. Chapter 8, page number 155. Severe acute malnutrition. Am I audible to all? Severe acute malnutrition. It is defined by very low weight for the height, by visible severe wasting, or by the presence of nutritional edema. Okay, we'll see the examples. In severe acute malnutrition, based on the age of the child, there would be severe wasting. That means the child would be so thin that you can see the child's entire skeletal system. Yeah. Or if the child is slightly elder in age, then the child may have nutritional edema all over the body. Okay? Swollen body. So it can go in any of these two extremes, usually based on the age of the child. Okay. So that is severe acute malnutrition. So how do we check that? How do you see that if the child is inching towards malnutrition or not? So this is one measurement, one of the anthropometric measurement that is done in pediatrics for kids who are under 59 months of age. Okay. So for these children, that is children who are under the age of 5. For these children, mid upper arm circumference is checked. Okay. So to check mid upper arm circumference, you have to first see the length of the area from your shoulder to the elbow, from the child's shoulder to the elbow. Find the midway of that. Okay. First you find the length of that area, shoulder to elbow, divided by 2, so that you will find the mid length. In that mid length, you have to place a tape. You can use a simple measuring tape as well. Okay. So place a tape in that mid upper arm area along the circumference of the arm, and then you measure it. What is the circumference of the arm? Okay. It should be more than 11.5 centimeter. Okay. If it is less than 11.5 centimeter, means the child is suffering from malnutrition. Wasting has begun. The child is malnourished. Okay. So that is the mid upper arm circumference. Anyone can do this. You can teach mothers of young children. Okay. At home itself, these mothers can regularly assess the nutritional level of their child. And if the child is inching towards that 11.5 centimeter, okay, immediately a treatment or a diet plan can be started. Okay. So that's how you assess severe acute malnutrition. So coming to the classification of severe acute malnutrition, there are two types of classification. One is clinical severe wasting, nutritional edema, complicated or uncomplicated. Okay, in severe wasting, the another name for that is marasmus. Okay. Again, the mid upper arm circumference is very less than 11.5 centimeter in these children. in severe wasting because they have lost a lot of subcutaneous fat as well as they have lost the muscle mass. Okay. They have lost muscle mass and they have lost a lot of subcutaneous fat as well. Okay. So that is the uh, upper arm circumference. It shows in severe wasting. Next is kwashiorkor. In kwashiorkor, we call it as nutritional edema. Okay. The entire body is swollen because there is fluid retention. Fluid get trapped in between the cells, interstitial spaces all over the body. Usually it is seen in distended abdomen. Abdomen is it appears very distended, full. Okay, swollen ankles and all. So these are the signs and symptoms of nutritional edema or kwashiorkor. Medical complications of this, either you may face an uncomplicated severe acute malnutrition or complicated severe acute malnutrition. In uncomplicated, at home itself, nutritional therapy can be started, and the child can gain weight, and the child will be on the growth track back again. Okay, that is uncomplicated severe acute malnutrition. It does not have signs of infection or it does not require any hospital administration. Okay, use when the mother is given ready to use food to regularly feed the child. Okay, ready to use food are free of cost. It is given from the Anganwadis and primary healthcare centers. Okay, when mothers use this for the child at home, a nutrition therapy automatically starts, and not need of hospitalization here. Okay, but in case of complicated severe acute malnutrition, hospitalization is required. Clinical care is required. The child may have infection, more than one infection. Okay. Metabolic disturbance, severe anemia, severe vitamin A deficiency. If not treated, it can lead to blindness, complete blindness. Okay. So these cases has to be treated under uh, under a pediatrician in a hospital. The child has to be admitted in the hospital. Usually, the first few days, the child will be admitted in the pediatric ICU, and then the child will be, after the initial treatment is done, slowly the child will be moved to a general ward, observed for a few weeks, and then sent back and then discharged. Okay, so that is complicated severe acute malnutrition. So two main types is marasmus and kwashiorkor. So in detail, we will see what all signs and symptoms do you see in a child who has this. So in marasmus, uh, it usually happens to kids who are less than 1 year old. Okay, very young children, because they are not taking enough calories that is required for their growth. And children who suffer from marasmus, they will face growth retardation. They will not grow as high in their height as they're supposed to be for that particular age. Severe reduction in body weight. Okay, they will lose a lot of subcutaneous fat, muscle mass. So automatically the body weight reduces. They're very shrunken. The abdomen is very shrunken. Okay, subcutaneous fat is not preserved at all. It is used up by the body. And because of that, the child's ribs and also bones are prominently visible. Okay. And the child is a voracious feeder. The child wants to eat, the child keeps on eating, but is never satisfied. Okay. There is no sign and symptoms of fatty liver. Edema is not present here at all. Edema is swelling. Okay. And the child will have an old man kind of face because everything is shrunken in, wrinkled and shrunken in because of the loss of subcutaneous fat. So automatically the child looks very old face wise. They will look much older. No hair changes is noted here. Dry, wrinkled skin. They are alert, but they are irritable. And they require adequate amount of protein, fat, and carbohydrate. All these macronutrients are required to gain back their health. protein, fat, carbohydrate, everything is required because if you see, they have lost their fat. Okay, even the subcutaneous fat is lost. You have to give it back to the child. Protein is lost from muscle loss. Lack of energy because of no carbohydrate in the diet. Calories are not being met. Okay? So that is what marasmus is. Kwashiorkor, the opposite of it, it's usually seen in elder children. Okay, little bit older children, 1 to 5 years of age. And it's usually because of low protein intake. The child may be having carbohydrates and fat, but protein is scarce in their diet. Mild growth retardation, not too much, mild reduction in the body weight, but still the body weight will not fluctuate much because the body weight, it is coming from water retention. Okay? The child has a protruding abdomen and subcutaneous fat is reserved. Ribs are not prominent because of edema. You will not see the child's bones much. Enlarged fatty liver because it affects fat metabolism. Edema is present all over the body. Swelling is there. Usually you will see a distended abdomen. We call it ascites because in the abdominal cavity, in the peritoneal cavity, the fluid gets filled. Okay? They will have moon face. It's again because of edema. When you have overall body edema or when you wake up in the morning, if you didn't have a nice good sleep, you will wake up with a swollen face. Okay, that it looks like a moon faces. Okay, because of the swelling. Hair is very sparse here and there. Okay, they lose a lot of hair. Then flaky skin, sparse hair, flaky skin, lethargic. The child requires adequate amount of protein to bounce back to normal health, but the child may have enough amount of calories from carbohydrates and fat, but protein is missing. Okay? So is the classification clear to all? Then we have marasmic kwashiorkor, mixture of two, usually seen in children who are around the age of 2 and 3 in midway. Okay, because marasmus is usually seen in children who are less than 1 years of age. Kwashiorkor is seen in children who are between 1 to 5 years of age. Midpoint of this is 2 to 3. So that is called marasmic kwashiorkor. Okay, they will have features of both marasmus and kwashiorkor. So the edema, what features do we have from kwashiorkor? Edema is there in the abdomen and in the ankles, in the feet, okay, legs and hands also. But the other part of the body is like rib, upper arm, upper legs, they are very skin, very thin and very skin. So those are the features from marasmus. So it's a mix of both. Okay. Swelling in the ankles, abdominal distension because of ascites. Okay. And swelling in the hands, arms, the palm region. But the remaining part of the hand is very thin, very low in muscle mass. You can see here a child, okay, arms, legs, ankle, and abdomen. It is there is edema. But if you see the hand, it is very thin. Okay, lower hand has edema, upper hand has no fat at all. So that's a mixture of marasmus and kwashiorkor. Even in the chest, if you notice, you can see the ribs of the children of this child. That is a classification of marasmus. But abdomen is distended. That is the feature of kwashiorkor. Okay. Then different types of growth retardation. You can see a normal child here. Normal child has a normal height, normal build and body in terms of weight gain. You can see a stunted child, height is not as equal to the normal child, okay? But the body mass will be okay as compared to the child's height. The child may have enough amount of body mass, but height is not there. So that is stunted. You don't grow, you're not able to grow vertically, okay? Then wasted child, height almost equal to a normal child, but not as equal. Height is not an issue here, but if you see the body, the child is severely wasted. So different types of childhood malnutrition. This is how you can classify a normal child, okay, with a healthy height, healthy body weight. Wasted child, height may be there as high as a normal child, but weight is not there at all. Very thin, very slim, okay. Stunted child, they may have adequate weight based on their height. They are not overweight or underweight. Adequately they have the weight, but they are not having the height. Okay, that is stunting. Then underweight child, again, they will have issues with the height and weight both. Not as high as a normal child, but somewhere in between. So what changes do you see in the organs? Systemically, what changes you will see in a child who suffers from kwashiorkor and marasmus? Digestive organs, absorption will be inhibited. Okay, even if the child is eating food, absorption is not there because the muscles and the cells have undergone atrophy. Atrophy means they have reduced in their size. That is atrophy. So they will not function as normally as the normal cells. The liver, what happens to the liver? Fat accumulation will take place in case of kwashiorkor because the liver is not able to digest fat properly. Bile salts may not be produced in a enough quantity to digest to metabolize the lipids. Okay, so big fat globules will end up in the liver, get deposited there. That leads to fatty liver. The cardiovascular system, heart muscles will reduce in their size. Cardiac output will also be less. Hypotension will be there because the cardiac output is not the heart is not able to push much of the blood. Then kidneys, protein will be present in the urine, mild levels of protein in the urine because the GFR rate, glomerular filtration, kidney filtration rate gets affected. And also if the child has infection, this can worsen. Okay. Then you have immunological system. What happens to the immunity in case of malnutrition? Obviously, it drops as well. T cells will not be produced in enough quantity by the thymus gland because the thymus gland is sinking. Thymus gland is there for your childhood to produce T cells for you. Okay, but once thymus gland shrinks completely, there is nobody to produce T cells. So, what T cells you have managed to produce during your childhood, with that you have to continue with it. Okay? So, if the child is affected by malnutrition, the thymus gland will not produce enough amount of seeds. Then mental development, again, absence of essential fatty acids in the food that will affect the way how your DNA, RNA is formed, how your vision is formed, how your central nervous system matures, these will get affected if you don't have essential fatty acids in the diet, which is definitely rare in a malnourished child's diet. Then hormones, you can see table 8.2. Those who have the textbook, you can mention the page number as well. It's 160. If it is the same page number for you, hormones, growth hormone reduces, insulin reduces with malnutrition. Insulin like growth factors, these are also hormones that reduces. Epinephrine that increases. Thyroid hormones, they reduce. Page number 165, those who have the new textbook about the hormones. So you can just go through the different names of the hormones and what happens to it. Arrow mark is given up and down. So what happens to that hormone while the person is malnourished? So far, is it clear to all? Then you have the biochemical and metabolic changes. Protein metabolism is interrupted. Essential amino acids are not there enough. Continue the protein metabolism. There will be low albumin levels in the blood. Also in marasmus, the concentration of the child is low because they don't have enough essential amino acids to help improve with the child's pain development. Lipids, lipid metabolism also goes down. Liver is not able to produce enough amount of bile salts. So that will go down. Then carbohydrate, blood glucose is usually normal in these kids. Glucose tolerance test is also done. That is also normal usually. Okay. Electrolyte and water metabolism, dehydration will be there. Deficiency of potassium, fluorine, they're all water-based minerals. Deficiency of that, and also drinking good water that also has enough water of minerals. So that deficiency will be there. Vitamin A, immediately, usually any malnourished child, if they require hospitalization, immediately on day one, vitamin A doses are given, high doses are given. Treatment. So you have the nutritional treatment based on food, taking care of their energy requirement. So around 150 to 200 kilocalories per kg. What is the child's weight? Based on that, 150 to 200 kilocalories per kg of body weight is the average and energy requirement that you have to target. If you have an elder child, little bit the child who are older in age, they may require 150 to 175 kilocalories per kg of body weight. Okay, those are the energy requirements. Protein, 5 gram of protein per kg body weight should be given. By giving milk at least 3 times a day. Milk is a really good source of protein, vitamin D, and other vitamins and minerals. So if you give at least milk 3 times a day, that will help. Then fat, 40% of the total calories can come from fat, which the child can actually tolerate. Saturated fats are much better, like butter, milk, coconut oil. Okay, butter and milk, why? Because it has vitamin D. And vitamin D is absolutely essential for young children. Okay, so it's always better to go for saturated fats. They are really good for bone health. And then for vitamins, vitamin A deficiency, that you have to be very, on the day of admission to the hospital, vitamin A dosages are given, large dosages are given. Management, there are phases of management. Initial treatment. So initial treatment is the day when the child is getting admitted in the hospital, usually in the ICU, okay, because the child may have life-threatening conditions like multiple infection, sepsis, okay, hypothermia, hypoglycemia. If the child stays in hypothermia and hypoglycemia for a bit longer, it will cause complete and permanent brain damage. Okay. So initially, when the child comes for treatment, if it is a malnourished child, and if you see these signs and symptoms, the treatment has to be continued in an ICU. Okay. All the deficiencies are corrected, and then you have rehabilitation. So after the ICU, when the child is being moved to general ward, okay, feeding is still given. The mother or the caretaker is taught how to feed the child, what to feed the child, okay, at what time the child should get feeding, all these things, because different doctors will suggest different time frame of feeding. Okay, that we have discussed in one of the previous sessions. You can check that. So rehabilitation is usually done in general wards. And finally, follow up. After general wards, when the child is discharged, after going home, it also the child has to come back with their parents on a regular basis to see if there is any alcohol or like any hospital acquired infection present in the child, or if the parents are still taking care of the child, the caretakers are taking good care of the child, or does the child require any more assistance? So that is seen in follow-up. So these are the treatment strategies used. Is it clear to all? So here you can see the table form of the treatment. Initial days in the ICU, hypothermia, hypoglycemia, dehydration, these are corrected. Day 3 to day 7, step down ICU, okay, electrolyte imbalance, infection, micronutrient deficiencies will be corrected. And then rehabilitation phase will start in the general ward, okay, where the child is being fed, increase the feeding to recover the lost weight, catch up growth, because now you want to catch up what the child has lost with in comparison to their peers. Okay. If the child was supposed to weigh 8 kilograms and the child is just 5 kilograms. So in the rehabilitation phase, you will start at extensive feeding for the child, focusing on appropriate weight gain. And finally, discharge. And after discharge, follow up will still continue. parents have to bring the child back to the hospital, back to the consultant to see if everything is still going fine or any further assistance is required. Coming to principles of management, dehydration has to be treated. Very important. And how do you treat dehydration in kids? Oral rehydration solution, ORS. Okay. If you can make it at home as well, take 1 liter of water, boil it, let it cool down. Take 20 gram of sugar or glucose, dissolve it in that boiled and cooled down water, and add a pinch of salt. Okay. So you can make the ORS at home. And this ORS, this 1 liter of water has to be completed within 1 day. Don't keep it for the next day. Infections, antibiotics will help. And any form of infection, even if it is parasitic infection, anti-helminthics will work. So find out what infections the child has, what different kind of sepsis the child will be having, and accordingly treat it with antibiotics, antifungal, antiviral, or anti-allergen. And also hypoglycemia, very low blood sugar level. So putting glucose in some water and giving it to the child will also alleviate the hypoglycemia. Otherwise, the child may get convulsions, become stressful. Hypothermia, since there is low blood circulation in the child's body, there is not enough blood volume. Heart is very slow to pump the blood. So blood circulation naturally goes down. So that's why the child suffers from hypothermia. Because good blood circulation will keep your body warm. Then you have congestive heart failure. So congestive heart failure, as I mentioned earlier, a heart is too weak to pump blood for the entire body. Okay. So it pumps in a very slow rate, or it is not able to, it does not have the ability to pump it completely. So that is the congestive heart failure. And there is also not enough fluid in the body, dehydrated body. There is lack of fluid in the blood. So the heart feels it very difficult to pump it out. So these are the diets that we give in by to correct marasmus and kwashiorkor. We have F75 and F100. That is formula 75, formula 100. Why is it called F75, F100? F75 will give you 75 kilocalories per 100 ml. F100 will give you 100 kilocalories per 100 ml. Why 100 ml? Because you need 1 liter of water, and this formula 75, you will empty it in 1 liter of water. Okay. 10 times a day, 10 times a day, you have to finish this F75. Okay. So every time you give it to the child, 100 ml, 100 ml is what is given to the child in a regular break. Okay. At 9 a.m., 100 ml will be given. So the child has 75 kilocalories. At 11, another 100 ml will be given. So again, 75 kilocalories. Okay, so every 100 ml of this formula diet, if this diet is mixed in 1 liter of water, every 100 ml of it will give 75 kilocalories. That's why it is called F75, formula 75. Okay, F100 will give 100 kilocalories per 100 ml. Again, same 1 liter of water you have to take. Empty this sachet in that 1 liter of water. Mix it thoroughly. Take 100 ml, give it to the child. After a few hours, again 100 ml, give it to the child. So the content of formula diet is given on the screen. You can see milk powder is used, dried skimmed milk, sugar, any cereal flour, vegetable oil, mineral and vitamin mix to correct any macronutrients. nutrient deficiencies. Okay. Is it clear to all about formula diets? Next, feeding on admission when the child is admitted in the hospital. How do you feed the child? Don't overfeed the child, otherwise, it will overload the child's intestine, liver, kidneys, and it will fail. Okay. Put the child on IV therapy slowly, one by one. All the critical phases, critical areas of the child's survival should be treated, like hypothermia, hypoglycemia, coma. Okay, these things have to be treated, and then you will move to the nutrition. Prevention of blindness should also be treated initially. Then after it is successful, feeding or admission is successful, the child is well hydrated, the child has no infections at all, because using antibodies you carried out that antibiotics, you carried out that issue as well. Okay, so now the child's appetite will come back. Okay, so the child may ask for food or say that if the child is hungry, so you will understand child's appetite for food has come back. So usually within 2 to 7 days, when the child is admitted, the child will move into this improved appetite phase. The child will be hungry. So this is where formula 100 will be given. Okay, because in feeding on admission, usually formula 75 is given, because you don't want to overload the child with calories. Okay, once the child is a little bit stable within 1 or 2 days, then the child will be given formula 100. Then deficiencies, vitamin A deficiency, immediately it has to be corrected. Otherwise, the child will go blind for the rest of the life. Vitamin A deficiency has to be corrected. Vitamin D, vitamin E, K, all the fat soluble vitamin deficiencies has to be corrected. The nutritional rehabilitation, making sure that the parents, once the child is admitted and discharged, and they go back to their home environment, it is not the same story all over again. The parents or the caretakers are making conscious efforts and decision to improve the health of the child even further. Okay? So that comes under nutritional rehabilitation. And if the child is under 2 years of age, every 4 hours, formula 100 diet has to be given. Then follow up once the child has been discharged. Uh, Within 1 month, you can't increase the child's height, okay, or you may not increase the child's weight to a targeted weight, but at least whatever principles you are following regarding diet, it is working. The child is in a much better state. So once the parents take the child away, you have to educate the parents regarding what they have to do, how to have to cook the food, what kind of food has to be given, okay, like that. So these information is given in the follow-up stage. So far, is it clear to all? Usually it is 1 pack a day. Okay. During convalescence, you means the child's follow-up period is also over. Now the child no longer has to uh, visit the doctors again and again. The child was discharged, follow-up was done 2, 3 times, and then it is the convalescence period, means maintenance of health. Okay. Increase the quantity of existing food, whatever food the child is getting, slowly increase the quantity of it. Focus on calories and protein requirement, so that the child is not the child is not hungry again. Add oil or ghee, 1 teaspoon of it, at the end after preparing the food while serving it to the child. When you ready the plate for the child, while you serve it to the child, put 1 spoon of oil or ghee on it and then serve, because you're not increasing the quantity, but the calories, it is dense. It is calorie dense. Give the child mixture of cereals and pulse like khichdi, porridges and all. If the child can, if the parents can afford milk, eggs, okay, that has to be given. Skimmed milk has to be given. Whatever food is available locally, seasonal food has to be given. So that is more cost effective. Then you have this rough diet. We call it Malai mix or rough diet. Ready to use therapeutic food. It's peanuts, okay? It's like cheeky peanut, roasted peanut with sugar, milk powder, okay, and some fat. It also has vitamins and minerals, okay? This rough diet was produced by the NIN, Nutritional National Institute of Nutrition in India. Okay? So it does not require a fridge to store. It does not require any cooking. Just you have to knead the package properly, tear it, and the mother will give the package to the child. The child can squeeze and eat what comes out of this package. It is usually peanuts. Okay, it is calorie dense. So one sachet, if the child is able to finish this one packet, it means 500 kilocalories the child has eaten. 500 kilocalories the child has eaten. One sachet is equal to 500 kilocalories. Okay. Usually given to children who are more than 6 months of age and who suffer from severe acute malnutrition. For them, this is given. Rough diet is given. Okay. And it is hygienic as well, because it is packaged in a sterile package. It is hygienic. There is no fuss for the mothers to make it. They just have to open it and give it to the child. Like chocolate, the child will keep on eating it. Okay. So under the prevention strategy, how as a country, as a community, how can we prevent severe acute malnutrition? So first strategy is health promotion. Target pregnant and lactating women. If mothers know the importance of certain nutritional aspect for the child, it can be prevented. Okay. If the mother is not educated, well read, illiterate, she does not know about caretaking, child rearing, it puts a risk of the child getting malnourishment. Okay. Promote breastfeeding as much as possible, at least till the age of 2, and give them the guidance of low cost weaning food. Weaning foods, importance of weaning food, the right time, right age at which weaning food has to be introduced. Okay. Measures to improve family diet, nutritional education, promotion of correct feeding practices for the children. Home economics, under home economics, you will teach the mother, like, without spending much, with their own budget, how they can improve the nutritional status of the children. Okay. Improving the family environment. If the family environment is very detrimental to the child's progress, development, the child may develop with a lot of physical and mental health barriers. Okay. In specific protection, the child should get all the universal immunization. All scheduled immunization has to be given. Protein and energy rich food like milk, eggs, fresh fruits should be given as much as possible. Fortified food has to be used. Like if you're going for milk, instead of getting the milk from the local dairy farm, go for packaged milk, because that comes fortified with vitamin A and D. It's much more secure for the child's health. Then early diagnosis and treatment, if the mothers have the knowledge of mid-arm circumference. Okay. they can catch it early. They can catch the disease conditions early. Then ICDS programs, Integrated Child Development Services, they give supplementary nutrition for all the underprivileged section of the societies. Okay. So the funding comes from ICDS. The ideology also comes from ICDS. You can avail the ICDS services from Anganwadi, primary healthcare centers, sub-centers, community health centers. Okay. That's nutritional education to mothers, to school children, to teenagers. Okay. As a part of your school syllabus, nutritional education should be a part of the school syllabus. And these are the actions that as a society we can take politically also, law and through justice and law system, legal system also. These actions can be taken to prevent severe acute malnutrition.